Good evening, colleagues. I'm Dr. Arvind. On behalf of MTL Pharma and the organizing team, we would like to invite for today's evening academic symposium as part of 45th annual MHG conference. We are indeed grateful to Dr. M.B. Agarwal sir for providing us an opportunity to organize this very interesting webinar, which encompasses topics of real unmet needs. On this occasion, I would also take the opportunity to wish you all a very happy International Women's Day. Without further ado, now I take the privilege to introduce Dr. M.B. Agarwal sir. He doesn't need an introduction. He has been the president of Mumbai Hematology Group. He has been the professor and head of Department of Hematology at Bombay Hospital, Mumbai, and he has been the consultant Lilavati Hospital and Fish Candy Hospital. So without further ado, we hand over the proceedings to Dr. M.B. Agarwal, sir. Thank you so much, sir, for the opportunity.
Thank you, Dr. Arvind. Good evening to one and all. This is 45th annual conference of Mumbai Hematology Group. The main conference will be held on Saturday and Sunday, and these are pre-conference satellite symposia, which are organized between 6:30 p.m. and 8:30 p.m. This is day 2 of these satellite symposia, and these are managed by Mice Ideas. I'm grateful to them for all the hard work they have put in managing the show. Today's first hour session is supported by MCure. In this, we have 2 parts. The first part is lecture by Dr. Gauri Kapoor. The lecture is entitled Real World Data in Clinical Practice for Treatment of Acute Lymphoblastic Leukemia, the Role of Asparaginase and PEG asparaginase. Dr. Gauri Kapoor does not require an introduction, just the formality. She's MD, PhD. She's Director, Department of Pediatric Hematology Oncology at the prestigious Rajiv Gandhi Cancer Institute and Research Center, New Delhi. Over to Dr. Gauri for her lecture.
Thank you, Dr. Agarwal. It's a privilege to be a faculty on your educational platform. And especially this is the 45th annual meeting of the Mumbai Hematology Group. And as you said, it's the satellite symposium. I also greet everybody on International Women's Day today, especially all the women in the audience and in the faculty. This is a very auspicious day for us. So starting with my talk about the role of L-asparaginase or PEG asparaginase. So these are some of the agenda points of my talk: its role in ALL therapy and the pharmacokinetics of asparaginase, and then what is the data from the international and the national world. As we all know, and as this graph here clearly shows, survival of childhood acute lymphoblastic leukemia over the decades has gone from less than 10% to more than 85-90% in this past decade with the modern therapy, which includes prolonged use of multi-agent chemotherapy agents. So what has led to this outcome, this excellent survival? Is it new drugs? Not really. However, it is the risk and response-based strategy and the fine-tuning and the better use of conventional agents. And most important of these has been the pegylation of asparaginase. So what is the data? It has been seen for last 3 to 4 decades clearly that asparaginase is a critical component of ALL therapy. So what does the data show? The data showed as early as in the 70s that for non-T-cell ALL, when they were randomized to receive an intensification of asparaginase during consolidation, there were fewer treatment failures in the asparaginase treated group. And if you see here, The pediatric oncology group also showed that even for the T cell ALLs and the T lymphoblastic lymphoma stage 3 and 4, there was definitely a survival advantage with intensifying asparaginase. All patients received asparaginase during induction, but during consolidation, but during prolonged or delayed intensification, they got intensive asparaginase in addition to the standard treatment. And if you see here, 552 patients, 357 had TALL, 195 had lymphoblastic lymphoma, stage 3 and 4. And there was a 10% improvement in event-free survival simply with high-dose asparaginase consolidation therapy. And you can see here the survival curves clearly showing this improvement. What about the discontinuation? So there has been a lot of controversy about it. How important is asparaginase? How much should we give? And so finally, in 2020, we got this report from the Children's Oncology Group, wherein they went back retrospectively and they saw the data for almost 8,000, more than 8,000 patients, in which the asparaginase had to be discontinued for various reasons. And the most two important reasons were hypersensitivity and toxicity, and grade 3 or 4 toxicity. And it was 12 to 25% rate of discontinuation. And as you can guess, most of these discontinuations were, some of them, of course, during induction, but many of them during delayed intensification. And they observed that for the NCI high-risk patients, those who did not receive prescribed asparaginase had a definitely inferior disease-free survival with a HR of hazard ratio of 1.5, which was clinically, statistically very significant, 0.002. This difference was not seen for NCI standard risk patients, except for those who were the slow early responders who also received further intensification in asparaginase. And when they did receive it, again, a hazard ratio 1.7% in favor of those who got the higher dose of asparaginase. So you can see omitting asparaginase. So what was the story here? Erwinase is not routinely available, was not regularly available to the patients there. The manufacturers sometimes had supplied it, sometimes did not. And if asparaginase or E. coli asparaginase toxicity was not replaced with erwinase, you can see here there is almost a 10 to 12% survival drop. A disease-free survival was inferior. But if these patients received erwinase as a substitute, then these patients had a similar survival to those who did receive all the planned doses of asparaginase. And we are talking here of the conventional asparaginase. So clearly the data shows that asparaginase intensification, asparaginase part of ALL therapy has made a big impact in survival. And once again, the Dana-Farber consortium therefore used this strategy to further intensify asparaginase therapy after consolidation, during intensification, delayed intensification, and increased it from 20 to 30 weeks, and again saw an improvement in survival. So there are, as we know, two sources of asparaginase, the E. coli, the bacteria E. coli, and the Erwinia. And we have these three formulations that we are familiar with. The native asparaginase from E. coli, which has been in the market for 40, 50 years, and most of us have grown up and trained using the conventional asparaginase. Then is the Erwinia, which is very expensive. Availability is intermittent and not available in India ever, not even today. And then is the newer agent, the pegylated asparaginase, which now has generics available in India. So how does asparaginase act? This enzyme breaks up the non-essential amino acid. L-asparagine is a non-essential amino acid, which is broken down to aspartic acid and ammonia. And when it is broken down, a normal, healthy human cell is able to resynthesize it using this enzyme called L-asparagine synthase. And thereon, protein synthesis continues. So normal cell stays healthy. However, lymphoblast cells do not have this synthase, L-asparagine synthase enzyme, and therefore it inhibits protein synthesis, leading to cell death. Therefore, we see that this asparaginase causes selective cellular toxicity of leukemic cells, which are starved of this non-essential amino acid, leading to stoppage of protein synthesis and cell deaths. So of the various preparations, as we said, these are E. coli is a bacterially derived, it's a bacteria, and asparaginase from E. coli is therefore because quite immunogenic, leads to antibody formation with repeated usage, and also causes hypersensitivity and silent inactivation in a certain subset of patients. Now, what is silent inactivation? Means antibody is present, but there is no clinical evidence of hypersensitivity. So antibody formation is bad because the enzyme is destroyed, and even though you give the drug, it is ineffective, and therefore it is similar to discontinuing asparaginase. But since therapeutic drug monitoring is not available and accessible to us routinely, therefore it is difficult for us to know, other than by a hypersensitivity reaction, whether or not the patient is having the antibody. The other thing about the E. coli native or the conventional form is that having a short half-life, we need to give it 3 times in a week. So what comes along is this pegylated formulation, polyethylene glycol linkage, and the 2 main preparations, PEG asparaginase, cal asparaginase, based on the type of linker that is used, whether a succinate or a carbamate. What does it do? It extends the circulation time of the enzyme, diminishing its immunogenicity, therefore reduces occurrence of hypersensitivity reactions, reduces occurrence of development of neutralizing antibodies. And the good thing is, because it has a prolonged half-life, we need to give it only once in 15 or 14 days. The anti-leukemic efficacy of the conventional and the PEG asparaginase are similar. They are equivalent. So what is the pharmacokinetic data showing? It shows that 2,500 international units per meter square, single dose during induction, 94% of ALL patients sustain therapeutic drug levels more than 100 international units per ml, which last at least 18 days. Why is it so? It is because the PEG asparaginase has an elimination half-life of a little over 5 days. Depending on IM or IV use, it is 5.3 or 5.5 days. The E. coli or the conventional one has a elimination half-life of 1.3 days, while the Erwinia-derived asparaginase has only a 0.65 day elimination half-life. And you can therefore understand how frequently we have to give the drug. And for good effect, we need a sustained depletion of asparagine from the blood so as to have a good anti-leukemic effect. Not only blood, but also the CSF. So as you see here, just to summarize these facts, the conventional or native E. coli, half-life 26 to 30 hours, pegylative 5 to 7 days, and the Erwinia just 16 hours. And therefore, also because the frequency, therefore, 3 times a week, once in 14 days, and actually the Erwinia needs to be given every other day. Antibody positivity, because of the pegylation, the immunogenicity is reduced and hardly 5 to 15% have antibodies and almost 45% to 70% in some studies with the native E. coli. For the Erwinia, I think we can skip because it's not practically available to us. So if we look at this pharmacokinetic graph, we can see very nicely that with a single dose of PEG asparaginase given, the trough level being here, 0.1 here, this is the dotted line, and you can see very nicely that the trough level, it falls below trough level after 18 days, after maybe 18 to 20 days. And this is another one which shows you the conventional E. coli asparaginase, where the trough levels are almost bordering at 0.1. But as I will show you in another graph, what happens with PEG when you give it every 2 weeks, you saw half the therapeutic trough levels are more than 100 for more than 2 weeks. So when we give the dose every 2 weeks, we have nice smooth levels above the therapeutic trough level, right? But when we give either the conventional E. coli or the Erwinia asparaginase, the levels keep going up and down, and actually on the third day, they are usually subtherapeutic. So as we can see here also, the antibody formation with, you can see these crossbars here. These crossbars are the conventional, the solid black bar is the PEG data. And this is showing you on the y-axis, the antibody, percentage of patients who develop antibody during induction, delayed intensification 1 and 2. And if you see here that in induction, about 12% have antibodies, and during reinduction, almost 40% will develop antibodies with the E. coli asparaginase. But the PEG asparaginase group, you can see less than 5% during induction and about 10% or so during reinduction. So clearly, the immunogenicity is less with PEG. So what then is the question? So the question was that we had in the past few years, earlier we used to have only one brand of E. coli asparaginase, the native one, the conventional one. However, many generics came into the market and people were wondering how good are the generics. And this study, you can see, it is done from Tata Memorial, Bombay. And it clearly shows that of these various 9 generics they used, many of them had trough levels below this 100 mark here. This is the solid line, and you can see the mean levels over here. They are all showing trough levels, mean trough levels below 100. So there is definitely an issue about the quality of the generic asparaginase. It's an enzyme, therefore a lot of care and a lot of technology goes into preparing this drug. And if you see here, when they checked, this is also data from Tata Hospital, British Journal of Clinical Pharmacology, you can see 60, 80, 70% had trough levels less than 100 international units per liter. So that was worrisome. Similarly, the study is from Vaskar Saha and group from Kolkata, TMC Kolkata, and they also found that the biogenerics had unsatisfactory quality. Again, at 48 hours, the trough levels were good, but when you give it out after the 3 days, Friday, Monday, Wednesday, Friday, when we were giving, then Friday to Sunday, the level dropped below 100. So with all these concerns, they also looked at the biochemical nature of the drug, and what they found that the drug purity was an issue and there were more aggregates. The expected was less than 5%. As you can see, all these preparations had 6, 10, 17% aggregates, which caused more reactions and problems with the asparaginase conventional E. coli generic. So therefore, with all these things in our mind, when the pegylated version generic came into Indian market, initially only for the hypersensitivity patients or relapsed patients, then we were very worried whether this would be actually a good quality drug or not. Therefore, in our hospital at Rajiv Gandhi Cancer Institute, we decided that we will do therapeutic drug monitoring and see whether this matches the conventional E. coli asparaginase. We were using Lunase and then came Hamcel, so we compared the patients. And this study that I will share with you is the one which was done by one of our fellows, Dr. Chintan Vyas. So we took all newly diagnosed, this was prospective, all newly diagnosed patients 1 to 18 years. The study was between June 14 and May 16, and we used the ALL-BFM backbone. And patients were assigned, this was a convenience sampling and patient family preference because PEG was more expensive. So we used Lunase versus Hamcel during induction and consolidation. So the same patient received the same product in both arms. And I may tell you, all the drug was bought from the hospital, pharmacy, and it was proper, the cold chain was properly maintained. So there was no such issue in our study. And what did we find? We found that we used a protocol in which BFM uses 5,000 during induction, 5,000 international units of Lunase, and they use 6 doses starting from day 12 of induction. Similarly, during the consolidation or reinduction, which we call cycle 2A, 10,000 international units, 6 doses, and you can see the days here, the protocol. What we did in the study arm, we used pegylated and replaced it by 1,500 international units per meter square. Why we chose this dose was we thought 2,500 might be having very high levels. We don't need those. And the Dutch clearly showed that 1,500 provided good therapeutic levels, trough levels. So 2 doses, day 8 and day 22 during the routine visits. So all these intervening visits for our patients could be avoided. So also similar exact we use for the consolidation or 2A cycle. And what we found was that the trough levels in all patients during induction were above trough levels for both the arms. There were 52 patients in the native asparaginase or Lyonase arm and 54 in the Hamsin arm. And we found that these were the mean levels. Definitely the PEG had higher trough levels. I'm not showing you the graph in the interest of time, but I may tell you that these were good. The most important thing we found was that during induction, both were good, but during reinduction, 13% of patients in the Lyonase arm had very low levels, showing that a significant percentage had either silent inactivation or hypersensitivity. And even this 13% is important for us because Erwinase is not available routinely for our patients. It's too expensive. So access is not there. We also looked at toxicity and found it was pretty similar with the PEG, that means with the Hamsin versus the Lyonase. So the results clearly showed that, and since these results showed that we had good trough levels, we continued with Hamcel and have switched to the pegylated asparaginase, the Hamcel, since 2016 and have had no problem. Definitely the hypersensitivity that we clinically see in our patients is much less with Hamcel than we were seeing with the Lyonase. There is no doubt about it. So other studies have used the biosimilars after the post-marketing of this product. And they have also, this is a study from Tata, which they have used for relapsed patients. And they have found that it was a safe drug. There was no anaphylaxis. And the other side effects, which are reported with L-asparaginase, these side effects were quite similar. And it was a product which could be safely used in patients. They have also done comparison with Oncospar, which is the innovator drug, and they have done the bioequivalent study of it using intramuscular PEG asparaginase, and they found that the curves very nicely matched Hamcil versus Oncospar. Even the trough levels came very nice. So they also found good results with it. Subsequently, and even previous data, the various clinical trials that have come from the US, clearly after 2006, most of the Western countries have switched to PEG. And you can see this CCG study, Dana-Farber study, all of them have shown that with pegylated asparaginase, the clearance of blasts is definitely better. And obviously, because there is a sustained trough level, it doesn't fall below the therapeutic trough level in the intervening period. So since you can see since 2006 in the Western world, pegylated asparaginase is first line. And in fact, because of the problems with asparaginase generic and the data that has come out, PEG asparaginase has been added to the WHO essential medicine list. So if we just look at in a summary slide, the differences between the native L-asparaginase E. coli and the E. coli PEG asparaginase, we clearly see that the PEG is lower immunogenic. So there are fewer adverse events like hypersensitivity and fewer antibody formations or lesser silent inactivation. Because it has a longer half-life, so there are fewer injections to be given, and there are definitely less number of visits, reducing hospital visits. And this is really important during induction. So what do we conclude from this? What is our take-home message? Asparaginase is a critical component of lymphoblast ALL therapy. Discontinuation is proven to reduce survival. The duration of asparaginase depletion and is an important independent prognostic factor in various studies. So wherever there is discontinuation, the survival has dropped, whatsoever be the reason. Sustained depletion of asparaginase is better achieved with the pegylated than the native form. And it has definitely got a convenient dosing schedule once in 2 weeks. Internationally, PEG asparaginase is the current standard product. So in fact, the native form is not even available there. In India also now, many centers are using pegylated, but there'll be a word of caution. We should ensure good quality product. I may also say, and reinforce that it is not easy to do therapeutic drug monitoring, and we have also not been able to continue to do it in our own lab because of the non-availability of the kit. So we have to be a little careful. With these few words, I would conclude and thank you. Childhood cancer, as you know, is curable, and February was International Childhood Cancer Month. So we had this little support group meeting in which our survivors have clearly said that we need to advocate for childhood cancer, and we shall fight and win over it. So kudos to them. Thank you very much for this opportunity.
Thank you, Dr. Gauri. Wonderful lecture with Indian data and data from your own institute. Fantastic. If there are colleagues from here who would like to ask questions, you are Dr. Shruti.
Thanks a lot, ma'am, for the update. It is always a pleasure to listen to you. Just one quick question, ma'am. Like at a small center like ours, we sometimes do not have many patients to, distribute the drug so that we can buy one vial and distribute it. So is it possible to keep the vial for a few days, like at least during induction, the same vial can be used or not? I just wanted to learn from your experience.
So frankly, when we were doing the study, only then were we using the therapeutic drug monitoring. We do not have access to it. And at that time, we wanted to make sure that we were not doing anything wrong. So I can only say 24 to 48 hours, because once you open the vial, there is no bacteriostatic agent in it. And people from TMC Kolkata had reported that when they were reusing the vials, they had lots of problems. So I cannot say that, but if the company can get the kits and do the levels, that would be interesting, but there is no bacteriostatic in it. So it can cause infections. So I will not be able to say. So I will say 24 to 48 hours. I cannot vouch for more than that. We did not have any problem with 24 to 48 hours.
Sure. Thank you.
The good news for you is that MCure may soon be coming out with the vials of smaller doses. So that may be very useful for the pediatric patients. Any other question, please? Dr. Gauri, what do you prefer between IM and IV route?
We only use intravenous, and the intramuscular has a longer half-life, elimination half-life, as I showed you, 5.5 versus 5.3. But during induction, giving IM is little difficult. There are 2 or 3 reasons for it. One is that the platelet counts are low. The second is we want to win over the confidence of the child. Every time he comes to hospital, you're going to give IM injection. I mean, you're a bad doctor. We are pediatricians. We want to have good rapport with children. I prefer IV, but when I looked at the pharmacokinetic data, it supports use of IV.
Right. Do you give any prophylaxis to prevent reactions?
So we don't use prophylaxis at all, but there is data to show that the reactions which occur with the pegylated asparaginase can be 3 types. One can be the hypersensitivity, 2 main types. So, and the other can be from the release of ammonia during with the asparaginase. As I showed you, the asparaginase breaks down asparagine into aspartate and ammonia. The ammonia, especially if you give it fast, and especially during induction, that causes many reactions. Some of them may be CNS as well. So what they say is, if you use, there is a study which shows if you give pre-medication, you reduce these effects, but also the pegylation, the polyethylene glycol also can cause hypersensitivity, which is not from the asparaginase. And if you did therapeutic drug monitoring, you would come to know. And then actually you can replace PEG with conventional asparaginase. So in that way, people have done the studies, but we do not use it. They say it reduces these other side effects, these other reactions, which can falsely tell you. But in the West, especially in the Dutch, they say do therapeutic drug monitoring for everyone to decide where you want to use Erwinis. But I think those rich countries, they can talk what they want. But the real world, that's us.
And what is your preferred dose schedule?
We use 1500 international units per meter square, and we use 2 doses during induction and 2 during reinduction. And it is the same for standard risk and high risk. There is no difference. Perhaps we are overusing it for standard risk patients during induction. The TMC Kolkata icicle uses 1,000 international units, and the US and they use 2,500. In fact, I may tell you, we used 2,500 for a few patients before the study. We had a lot of infection, and so we stopped using it.
Is it true that you have to distance it from adriamycin? Otherwise, you get more complications?
So from Wincrease, they are supposed to give on day 4. They say 2 days before. But somehow in our study, we did not have any problem. The levels were good, and if the level is good, we don't question it. And I may tell you the levels were like 500, 600. They were not like 150 or 200. They were very good levels. So we were very happy.
Thank you so much, Dr. Gauri. Unfortunately, we are left with only that much time to ask you questions. So thank you so much for being with us and educating us with this lovely talk and your personal experience from your center. Thank you.
Thank you, sir. It was a pleasure.
We'll move on now to the second part of this session, once again supported by MCure. And this is a lecture followed by panel discussion on optimizing the management of iron deficiency anemia with the IV FCM 1K. Lecturer and moderator is Dr. P. Prabhu, MD, FRCP, MRCP, FRC PET, hematologist, Apollo Hospitals, Chennai. And after his lecture, the panel is made up of Dr. Priyanka Samuel, Bhubaneswar, Dr. Ganesh Jaishetwar from Hyderabad, Dr. Dinesh Bhrani from New Delhi, Dr. Pranta Chakrabarti from Kolkata, Dr. Upendra Sharma from Jaipur, and Dr. V. Karthika from Salem. So over to Dr. Prabhu for his lecture.
Dr. Prabhu, you need to unmute yourself. Sir.
Thank you, Professor Agarwal, for asking me to present this about iron deficiency anemia and optimal use of parenteral using ferric carboxymaltose or ferric carboxymaltose 1K. I'm Dr. Prabhu. I'm a consultant hematologist at Apollo Hospitals, Chennai. 1 second. I think the slides weren't moving very freely. Just give me a couple of seconds, then I should be all sorted. Can you see my slides well?
Yes,
sir.
You can hear me well as well. So iron deficiency anemia is one of the commonest causes of all anemias. So if you look at it worldwide, most of the anemia, more than 2/3 of the anemia is due to iron deficiency. So it's a major public health problem. So, I'm not going to go through the basic concepts in iron deficiency anemia and how we treat it, oral iron, etc. I'm just going to look at how we treat iron deficiency anemia with parenteral iron therapy, with a special focus on ferric carboxymaltose, and how it's used in various situations where there is both absolute and functional iron deficiency. So, what is absolute iron deficiency? Absolute iron deficiency is where there is insufficient iron available, and that may be due to either inadequate iron intake or chronic blood loss or a heavy demand that doesn't keep up with where the oral intake doesn't keep up with a heavy demand. Functional iron deficiency happens when there is adequate iron stores, but there is inadequate iron supply or iron utilization or iron supply to the erythroid. So this results in certain chronic inflammatory conditions like inflammatory bowel disease, chronic kidney disease, and chronic heart failure. So if you look at absolute iron deficiency, you've got a ferritin level that's mostly less than 30 micrograms, and the transferrin saturation tends to be low at 20%. Whereas in patients with functional deficiency, which often is characterized by a chronic inflammatory state, you get ferritin levels well within the normal range or slightly above the normal range. but the transference saturation, which gives an indication of ion utilization, is on the lower side at about less than 20%. So this again, this picture is very well known to this audience. So this is how iron is absorbed from the gut. Ferric is oxidized into the ferrous form, and there is a diurnal cytochrome B, which transports iron, which actually facilitates this oxidization of ferric to ferrous form. And this ferrous form is transported across the cell membrane by a divalent metal transporter 1. And this iron is further excreted out of the enterocyte through the ferroportin for utilization for various aspects, predominantly for manufacturing erythrocytes or production of red cells. So this particular step where the iron that is there in the enterocyte is transported across the enterocyte membrane and used for erythropoiesis is heavily regulated by hepcidin. And we all know that there is an upregulation of hepcidin when there is chronic inflammation. And this upregulation of hepcidin can impact on this ferroportin mediated transfer, resulting in decreased iron utilization or what is called as functional iron deficiency. This is a concept that we need to understand before we proceed with this. So hepcidin blocks the basal-lateral iron transporter ferroportin 1 on duodenal enterocytes, macrophages, and hepatocytes. This results in a reduced intestinal absorption of iron and in a shift of iron from circulation to storage cells. Instead of getting used for manufacturing red cells, it gets stored. So these effects combined can create functional iron deficiency, which means there's good amount of storage iron, but the utilization is poor. So the two main indicators of iron status that one uses commonly in day-to-day practice is ferritin and transferrin saturation. We know that a ferritin level of less than 15 to 30 microgram per liter is diagnostic of iron deficiency. But if you have an active inflammatory process, a ferritin level of up to 100 microgram per liter can still be consistent with iron deficiency. A transferrin saturation below 20% reflects a reduced availability of iron for erythropoiesis, either due to total iron deficiency or due to functional iron deficiency as in chronic inflammatory state. So if you have a transferrin saturation of below 20% with a ferritin below 100 microgram per liter, that tells you that there is total iron deficiency. And if you got a transferrin saturation of below 20% and a ferritin above 100 microgram per liter, it's considered to be a functional iron deficiency. So we know that iron deficiency progresses through various stages where the iron stores and circulating iron is normal. It's towards the end that one develops iron deficiency anemia. Again, this is something that I'm sure is very well known, the audience here will be very well aware of. So hepcidin plays an important role in regulating iron absorption. In absolute iron deficiency anemia, you've got low hepcidin, whereas in anemia of inflammation, you have high hepcidin. So because of high hepcidin, there's reduced utilization of iron, so you tend to have low transferrin saturation, but a normal to elevated ferritin. This concept is important to understand because we do use iron infusion in certain chronic inflammatory state where the ferritin may be well within the normal range, but the transferrin saturation tends to be low. So now coming to, we're not going to talk about enteral iron, we are going to concentrate on parental iron. So we know that there are now several molecules of parental iron that is available. The first generation iron was the iron dextran. From that, we moved on to the latest molecules like ferric carboxymaltose and iron isomortoside 1000. So if you ask any medical student or any doctor, if you ask them what is the commonest side effect of iron infusion, the first thing everybody will tell is anaphylaxis. But with the newer preparation, I'm sure all of us who are in regular hematology practice will hardly ever have encountered an episode of anaphylaxis, leave alone serious allergic reactions. So anaphylactic reactions have become exceedingly uncommon, and even infusion-related allergies have become uncommon with the newer generation of iron preparation, such as ferric carboxymaltose and iron isomortoside. The reason for the main determinant of allergic reaction to parental iron preparation was the dextran or the carbohydrate moiety that is present in these molecules. If you look at the early preparations of iron dextran, the carbohydrate moiety was predominant and high molecular weight, which resulted in increased incidence of allergic reactions and anaphylaxis. The other advantage to the molecules that we have right now, like ferric carboxymaltose and iron isomaltoside, is that instead of repeated visits to clinic to have infusions, we can give up to 1,000 milligrams in a single sitting over just 15 to 20 minutes, and it's extremely well tolerated. So, as I told you, everybody, when you ask anybody about what is the common side effect of iron infusion, the first thing people say is allergic reaction and anaphylaxis. So, if you look at the immunogenicity of iron formulations, if you look at, there are two things one needs to consider when we think about side effects of iron. One is the immunogenicity, causing infusion reactions of varying kind, including very serious infusion reactions like anaphylaxis, and also release of labile iron into the circulation. We know that labile iron is toxic. We don't want, when the iron is being infused, we do not want a lot of labile iron in the circulation. So if you look at a molecule with the lowest amount of labile iron and the lowest amount of immunogenicity, you have ferric carboxymaltose. Whereas iron dextran, which is hardly ever used nowadays, had very high immunogenicity. So that way, a molecule like ferric carboxymaltose ticks two very important boxes. One is low immunogenicity, and the other is, decreased amount of labile iron. So, between ferric carboxymaltose and iron isomaltoside, is there any difference in immunogenicity? Is there a higher incidence or a lower incidence of anaphylactic reaction between the two different molecules? So there was one study that was published. This is basically based on people reporting adverse reactions between the year 2014 and 2017. There were two databases that was looked at, one called the Intravigilance and the other one is the Digibase. Both were based in the European countries. So between 2014 and 2017, they found that the number of severe hypersensitivity reactions per 100,000 defined daily dose was about 0.3 to 0.5 for ferric carboxymaltose and from 2.4 to 5 for iron isomaltoside. So iron isomaltoside, though compared to the older preparations, is less immunogenic or less prone for anaphylaxis. When compared to ferric carboxymaltose, there was a higher report of anaphylactic reactions with iron isomaltoside. I would like to know from the rest of the panelists as to what their experience have been. With my experience with ferric carboxymaltose, very hardly ever seen any serious allergic reaction. But with iron isomaltoside, I have seen occasional allergic reactions, serious allergic reactions. But again, this might just be an observer bias. But this particular report into drug vigilance registry shows that there is a higher incidence in isomaltoside. So this again, looking at on a yearly basis, you can see that the reported severe hypersensitivity reactions per 100,000 doses, daily doses, it's higher with isomaltoside. But what one has to realize is that even the high rate of hypersensitivity reaction is extremely small, 4 per 100,000 daily doses. So compared to the earlier preparation, the incidence of hypersensitivity reaction is much lower. So over the last 10 years, I think, at least in my practice, I tend to use a lot more parenteral iron right now than I did about a decade ago, simply because of the confidence one gets with decreased incidence of these serious reactions. And in our set of patients, at one point and they visit in clinic, you just ensure that they have enough iron, and you don't have to worry about them being compliant with oral iron, and you are sparing them of the suffering that sometimes is associated with oral iron. So you got the first generation, which has got all the big, heavy carbohydrate moiety, like the iron dextran, both high molecular weight and low molecular weight. Then you got the iron sucrose, and now you got the ferric carboxymaltose and the ferric isomaltoside. So this is an interesting picture of the ferric carboxymaltose. So ferric carboxymaltose has an iron core, and it's bound by a carboxymaltose shell, which results in a regulated release of iron. So ferric carboxymaltose injection contains iron in a stable ferric state as a complex with carbohydrate polymer designed to release utilizable iron to the iron transport and storage proteins in the body. It's a very stable, robust complex. It's formulated as a colloidal solution in the physiological pH. Due to the stability of the complex, ferric carboxymaltose does not release ionic ion under physiological conditions. So you don't have a lot of toxic ionic ion circulating in the blood. The iron hydroxide is tightly bound within the carbohydrate cage, so you don't get a lot of release of elemental or ionic ion, which can be toxic. So, of course, there have been studies which looked at ferric carboxymaltose versus oral iron. So, if you look at this particular study at day 21, 45.2% achieved complete response with oral iron sulfate, whereas 85.7% also had a complete response with ferric carboxymaltose. But if you look at day 42, that's about 6 weeks away. Almost all patients with ferric carboxymaltose received a were in complete remission from the iron deficiency anemia, whereas with the oral iron it was only 61.3%. So if you look at adverse effects compared to oral iron, the tall light green bars are constipation, diarrhea, nausea. So if you look at these are the, any one of us who has been seeing patients with iron deficiency anemia will easily attest to the fact that most patients with iron deficiency anemia, when they started on treatment, they report these gastrointestinal side effects, and this is often dose limiting. Patients hardly ever take their medication after the first 3 days because of this gastrointestinal side effect. We've done several things to reduce the incidence by asking them sometimes to take after food or just giving them an alternate day iron tablet. The gastrointestinal side effects are fairly significant. Abdominal pain, vomiting, upper abdominal pain, diarrhea, constipation, etc. The only important side effect that one needs to worry about with the iron ferric carboxymaltose that doesn't occur with oral iron is, of course, infusion and injection toxicity. This hypophosphatemia that is never seen with oral iron, but can be seen with ferric carboxymaltose. We will talk about that towards the end of this evening or in this end of this talk. So, if you look at the efficacy of ferric carboxymaltose in iron deficiency anemia, there are several studies which has looked at use of ferric carboxymaltose in several situations, like in inflammatory bowel disease, FCM versus ferrous sulfate. At week 12, response was about 76.5% versus 68.3%. In heavy uterine bleeding, again, at week 6, ferric carboxymaltose scored better. Postpartum iron deficiency anemia, again, ferric carboxymaltose is a much better agent compared to oral iron. Again, in non-dialysis dependent CKD and in dialysis dependent CKD, ferric carboxymaltose compared to IV iron was increased, proved to be more efficacious. Of course, there is the question of cost when you're dealing with thousands and millions of CKD patients. Of course, the cost of ferric carboxymaltose is much higher than ferrous sulfate, but however efficacy is, the desired, the more useful agent would be the ferric carboxymaltose. So I've just picked up a few studies which will very rapidly go through in the interest of time. There's an interesting study from Tanzania which looked at efficacy and safety of IV ferric carboxymaltose compared with oral iron for treatment of iron deficiency in women after childbirth. So if you look at, we'll just go to the conclusions. Intravenous iron substitution with FCM was safe and yielded a better hemoglobin response than oral iron. And they said that this was the first study that showed that there was benefit of using intravenous iron in a low income setting. So you can extrapolate this to our postpartum and antenatal clinics, where if you can do one single infusion of IV iron in the second or third trimester, we may have better outcomes. And also in the postpartum period, if you can just give one infusion of IV iron rather than oral tablets, we may have much better outcomes. So again, from the study, the red is the IV iron. It tends to be better both in terms of hemoglobin concentration and, of course, biochemical parameters. So again, in pregnancy, comparison of ferric carboxymaltose and iron sucrose, we have been using iron sucrose in the second trimester of pregnancy due to severe iron deficiency anemia, where we have to give multiple patients. The pregnant lady has to come several times to the clinic. Whereas with ferric carboxymaltose, we tend to just give one single 1000 milligram or 1K infusion. So this study was done in India. Treatment with FCM resulted in rapid replenishment of iron stores in pregnant women with significantly higher hemoglobin rise over a 12-week period. And this convenient dosing with lesser number of total doses to complete the treatment resulted in better compliance. So this is something that one can use in pregnancy. Of course, you cannot use in the first trimester. If I see a significant iron deficiency anemia that's poorly responding to oral iron, in the second trimester, my go-to option is ferric carboxymaltose. So ferric carboxymaltose versus iron sucrose, this is not just in pregnancy. Generally, you have a much better response at 4 weeks compared to iron sucrose. But of course, you have to say that the other big advantage of ferric carboxymaltose is that you have single visit to the clinic, whereas with iron sucrose, you have 3 to 6 visits. So I do not use Ganserini's equation to diagnose or to kind of work out the dose, because if you look at after calculating males and females, if you are a standard male or female, most of the time the total iron that's required falls between 1000 to 1500 milligram. So there's a much easier way to do that. So anybody less than 70 kg in weight, I tend to use 1000 milligram in one single sitting. Anybody above 70 kilograms in weight, I use 2 sittings of 1000 and 1500. So again, another very important situation where you use ferric carboxymaltose is in inflammatory bowel disease. So in inflammatory bowel disease, there is obviously an iron deficiency due to 2 reasons. There is continued GI blood loss, but there's also chronic inflammation and there's anemia related to chronic disease. So chronic inflammation results in high hepcidin levels, and that can result in poor utilization of iron. So this study looked FERGICOD is a randomized controlled trial of ferric carboxymaltose for iron deficiency anemia and inflammatory bowel disease. This looked at proactive mixing based dosing regimen with using 1000 milligrams on a proactive basis whenever the ferritin was less than 100 or the patient was anemic, and that had a good safety profile and resulted in much better outcomes. So not only not only there's a better hemoglobin, there's also improved quality of life in patients with inflammatory bowel disease in whom you will parenteral. In my practice, what I tend to do is when they are severely iron deficient, of course, you give 1000 to 1500 milligrams depending on their weight and the hemoglobin levels. After that, I proactively monitor them. I ask them to come every 2 to 3 months with a ferritin and a CBC. If a ferritin level is, although books say a ferritin level of less than 100, I use 50 as a cutoff. If the ferritin level is less than 50, even if there is a normal hemoglobin, I tend to replace at least 500 milligrams of ferric carboxymaltose. So I keep them on a regular follow-up. There are many young adults who have inflammatory bowel disease who have gone through this, university education and employment, just maintaining a good hemoglobin. So in inflammatory bowel disease, it's important to be proactive and look at ferritin levels on a proactive basis and replace iron with ferric carboxymaltose even if they're not anemic. Of course, again, in advanced chronic, in the interest of time, I think we rush through the rest of the slides. Because these concepts are very well known to this audience. Chronic kidney disease, there is an iron deficient state. Non-dialysis dependent chronic kidney disease, you've got the choice of oral iron versus IV iron. And most studies have shown that IV iron has a better efficacy result than oral iron. And ferric carboxymaltose is increasingly used in this situation and has resulted in much better outcomes in terms of improving hemoglobin levels and quality of life. And it can be also used in dialysis-dependent patients, including peritoneal dialysis patients. So FIND-CKD is a randomized trial of intravenous ferric carboxymaltose versus oral iron in patients with chronic kidney disease and iron deficiency anemia. Compared with oral iron, IV ferric carboxymaltose targeting a ferritin of 400 to 600 microgram per liter quickly reached and maintained hemoglobin level and delayed or reduced the need for other anemia management, including ESA. So in this particular trial, it was established that ferric carboxymaltose is an agent with much greater efficacy than oral iron. Again, another very important area where we tend to use IV iron is heart failure. So heart failure, there is a degree of inflammation and increased hepcidin activity, and there's also reduced iron intake and reduced iron absorption. And there can also be blood loss and medication related reduction in iron absorption. So, of course, when you are iron deficient, you're going to have reduced aerobic capacity, reduced endurance, fatigue, poor quality of life, and a worse prognosis for the heart failure. So, there are many trials which look at iron supplement in heart failure. In the interest of time, I'm not going to go through all of them in detail, but if you look at the results, most of the patients have patients who are proactively treated with ferric carboxymaltose had fewer hospitalizations for heart failure, and they had much better outcome and much better functional capacity at discharge. So, in fact, what most cardiologists tend to do is they check iron deficiency or iron deficiency. Of course, it won't be the classical deficiency. If any patient has got a ferritin of less than 100 micrograms or between 100 and 300 with a transfer saturation of less than 20%, you have to, and in such a situation, the hemoglobin is less than 15, you would call them iron deficient, and based on their weight, you would actually give them a ferric carboxymaltose either before discharge and also proactively monitor their iron status and give ferric carboxymaltose whenever it's indicated. See, this actually in our hospital is done proactively by our cardiologists who hardly know this. So, one very important side effect that ferric carboxymaltose has is called is hypophosphatemia. Compared to isomaltosite has much lower incidence of hypophosphatemia. The real world incidence of symptomatic hypophosphatemia is probably exceedingly low. But if you look at, none of us actually, none of us don't check phosphate levels for everybody after ferric carboxymaltose. Probably, if you look at biochemical hypophosphatemia, it's probably the order of about 15 to 20%. Whereas if you have symptomatic hypophosphatemia, it's probably the order of about 1 to 5%. So hypophosphatemia can cause several symptoms, mainly neurologic, mainly osteomalacia and severe fatigue. So if you're the patients that you have to really worry about hypophosphatemia are the ones where you're giving repeated intravenous iron infusions, like patients who have inflammatory bowel disease or patients who have menorrhagia, etc. So those patients you have to really worry about symptomatic hypophosphatemia. And if they're complaining of worsening fatigue, bone pain, or muscular weakness, then you definitely have to look for phosphate levels and correct them. In other patients, there is no need to proactively look for hypophosphatemia. So if you see low phosphate, delay further intravenous iron doses, and you have to switch to iron formulations which have less hypophosphatemia risk. So that more or less ends my whirlwind tour of how to use ferric carboxymaltose in real life. So over to Dr. Agarwal if he has some questions to me or to the panel, but I'll just put some very basic questions to ask.
So thank you, Dr. Prabhu, for your talk. 4 of your panel members are here. If they would like to ask you any question, Dr. Priyanka, Dr. Ganesh, Dr. Karthika, and Dr. Upendra. We have a minute to go. Have any question for Dr. Prabhu?
So I've just got question to the panel if they want to the answer.
Maybe we can just have one question. We have just half a minute.
So how often do you see hypophosphatemia in your practice? I don't proactively look for them.
I haven't seen it in my practice. I have been using IV iron quite frequently, but we haven't come across any features of hypophosphatemia. Might be we have missed it. We haven't monitored the levels, but maximum we have seen some sort of hypersensitivity reaction, but no cardiac issues as such.
But some patient at the time of infusion complaining of severe body pain, and after 1 or 2 days they develop severe body pain. I think that could be the reason. That could be a patient suffering from hypophosphatemia. So
I think we'll have to educate our patients on the symptoms of hypophosphatemia, but in real life, yeah, see with symptomatic hypophosphatemia. It's also possible with at least 1 or 2 cases.
Thank you, Dr. Prabhu, and thanks to the panelists. Thanks to MCure for supporting this particular session. And now we'll move on to the next session. This session is supported by Dr. Reddy's, and we have two parts of this session. In the first part, we have lecture by Dr. Vikram Matthews. This lecture is entitled AML Management, the Emerging Role of Oral Azacitidine and Midostaurin. Dr. Vikram Matthews doesn't require introduction. He's Associate Director, Professor of Clinical Hematology, Department of Hematology at CMC Vellore. So over to Vikram for his lecture.
Thank you, sir. Evening, everybody. I want to thank the organizers for inviting me to give this talk on the role of oral azacitidine in midostaurin. I think it's a fairly focused group, and most of us are aware that in acute myeloid leukemia, for the longest time, this is how treatment looked. There was remission induction with conventional cytosine, anthracycline, and you had the option of consolidation therapy with either chemotherapy, autologous transplant, or an allogeneic transplant. And even within that, the autologous kind of, not because data was not so good, but generally kind of lost favor as improvements in allogeneic transplant happened. And the general dogma was that there is no role for maintenance therapy. I would say for almost 4 decades, since the introduction of cytosine, anthracycline, close to 5 decades, up to 2017, this was the worldview of how AML was treated. But we know since 2017, there's been a rapid strides and development in the management of AML. Is the introduction of a whole lot of new agents. Many of them are targeted therapies targeted against particular molecular signatures that are seen in AML. And some of them have shown survival advantage, which actually is not easy to show in AML. One of them is midostaurin. And what's more interesting is a more recent data, there's a lot of confusion with regards maintenance, but a randomized control trial showing benefit of oral AZA maintenance in elderly patients who received intensive chemotherapy, who could not receive a transplant and went on to oral maintenance therapy. Of course, if you look at AML in general, even with conventional therapy, it's a very expensive disease to treat. And with all these targeted agents, for the most part, are not really accessible and are very expensive. I'm not even going to talk about all the immunotherapies and therapies that are kind of evolving. But even many of these targeted therapies are not available or very expensive. And so there's a significant role of generics, and this is something that has recently come in these agents, at least, as generics, whether it's FLT3 inhibitors or whether it's the azacitidine, which can have significant impacts. And I'd like you to point you to this book, if you have not read it, Emperor of Maladies. What is interesting in this book that I like especially is the concept of how ALL therapy has evolved. If you look at all the drugs that were available, all of them were available well before 1980s, but we continued to show significant improvements in survival from almost 50, 60% to almost 90% with the same agents. So the availability of multiple agents, the optimal dosing and scheduling of these agents through multiple clinical trials has improved the outcome of ALL. So similarly, the more the new agents in AML, it's not just the availability of a single new agent or the impact of that one agent as a single agent, but it's the potential that in future, the optimal dosing and scheduling of these agents is going to improve the outcome of AML. And AML, I think today is at the threshold of where ALL was almost 2 decades ago. So there is a lot of data and slides like this out there looking at combinational therapies in the setting of the new molecules that are available. And I only put this slide up not to go through this in detail, just to caution that many of this is not really evidence-driven. It's expert opinions of where AML therapy could potentially be handled. In some cases, like midostaurin and FLT3 inhibitors, there is good randomized controlled trial data. But in many others, like Azaven, for example, phase 3 randomized control trials are still awaited as upfront therapy, even in elderly patients. The whole molecular scenario and understanding of AML has exploded, there's a recognition of many molecular signatures, and it can be confusing at times, and many of them have been incorporated into conventional risk stratification. We recognize the favorable and the adverse, and I intentionally highlighted the StatFish for identifying favorable and the high risk, because I think this has some significance in induction therapy in AML. So for example, in the good risk, the APML obviously will change therapy dramatically, but even in the co-binding factors, there's a significant understanding of the potential for gemcitabine or azithromycin as upfront therapy. Obviously, it's not available all the time to us, but that's something that needs to look. In the high-risk group of patients, we know that the conventional 7-3 induction, the response, even in a young fit patient is not so good. And there may be an increasing role for hypermethylating agents or hypermethylating agents with azacitidine. And there's fairly good evidence of that with TP53 mutations. If you look at FLT3 mutations, one of the most common mutations, because we're going to talk about midostaurin predominantly in this talk and FLT3 inhibitors, FLT3 mutations are one of the most common mutations in AML, up to 25 to 30%. It's associated with a high WBC count and often seen with normal karyotype. But that's not essentially the entire picture, because remember, FLT3 ITD is also very common in APML, where it does not have an impact in the setting of the use of arsenic trioxide. But prior to arsenic trioxide, it was associated with a slightly inferior outcome with ATRA with chemotherapy. Now, what's very important is the presence of FLT3 ITD mutation has no detectable effect in achieving CR. So whether you have FLT3 ITD or not, your achievement of CR was equally good. But what was most dramatic was the high incidence of relapse in those who had FLT3 ITD, especially ITD mutations positive, with a rapid relapse, which was strikingly very rapid, often within the first 6 months. And there's also the recognition of the importance of the allelic burden and the ITD size on prognosis. So is there a difference in incidence of FLT3 mutation in our population of the West based on a fairly large series in our center? We don't think so. And even if you look at multi-center data, this is data through the Hematology Cancer Consortium of more than 4,000 patients, we don't think there's a difference in the incidence of FLT3 ITD mutations in our population, which is about 20 to 21% compared to what is reported in the West. Now, when you talk about many of these targeted therapies, often the question comes, how fast can your turnaround of results come, and does that impact delaying treatment? Will it impact therapy? In the case of FLT3 inhibitors, we start therapy on day 8. So obviously you need to have your FLT3 mutation result within day 8. For the most part, that is possible. But in this fairly large German study, what they actually showed was even delaying treatment by 8 days, if one did have to wait for therapy, if you're looking at starting therapy for a targeted therapy upfront, it did not impact. But again, this is data from a Western center, may not necessarily apply to us. Moving to the landscape of FLT3 mutations, the earliest one that was used was sorafenib. And sorafenib and midostaurin are FDA approved, as is gilteritinib, which has more recently been approved. Neither midostaurin nor sorafenib have single agent beneficial effects, while gilteritinib has shown single agent beneficial effects in relapsed refractory AML. Now, the early data with sorafenib is important to look at, because both in young adults and in older patients, the early data was not really very promising. There was an improvement in event-free survival, but did not translate to improvement in overall survival. But interesting, in a single center data, looking at addition of sorafenib as maintenance therapy with intensive chemotherapy, this is data from MD Anderson, showed a benefit in that as a very large number of patients study. And in the SORA-MAIN trial, looking at sorafenib maintenance post-allogeneic stem cell transplantation, this is a multi-center study, showed benefits of adding sorafenib as maintenance therapy in patients with post-allogeneic stem cell transplantation in AML. Coming to midostaurin, we know that midostaurin as a monotherapy has no significant benefit. However, the landmark trial, the ratified trial, has established the role of midostaurin in AML upfront therapy. AML, the midostaurin is usually added on day 8 after the completion of 7-3. And clearly, there was a benefit translating to an improvement in overall survival. And this is a therapy that actually changed therapy in the sense that for FLT3 ITD, one could today consider midostaurin as standard of care. And of course, newer agents are constantly challenging its position. Now, when it comes to targeted therapies in the context of India, one always has to look at the cost-benefit balance of these therapies. And whenever I think of these agents, what brings to my mind is what is the effect of this on the duration of neutropenia? Because, for us, the major challenge in intensive chemotherapy induction is the high induction mortality. And in this particular study with midostaurin, actually, there was no difference in the duration of neutropenia and time to ANC and platelet recovery, both in the midostaurin and placebo group, which is actually quite reassuring. And of course, in the setting of the clinical trial over here, there was no impact on treatment-related mortality either. It's almost impossible to ignore the venetoclax data in this era. Just to state that there's no role as a single agent, mostly in the combination with the hypermethylating agents. And today in relapsed refractory and even in newly diagnosed patients, phase 2 data is very promising with a combination of more intensive therapy like FLAG with venetoclax. Some word of caution when you move with venetoclax with more intensive therapy like FLAG, that there's a very prolonged duration of neutropenia, which in our setting with multi-drug resistance infection and fungal infections could translate to greater mortality. Now, when one talks about relapse, remember that with chemotherapy alone, more than 60% of patients relapse. Most relapses occur within the first 18 months. More than 3 years since diagnosis, relapses are rare. Post-transplant as well, 30 to 40% of patients relapse. And if you relapse within the first 6 months of transplant, the outcomes are very poor. When you talk about the principles of maintenance therapy, to maintain the remission status after induction and consolidation, it should be effective in that setting. It should be safe, not too many side effects. It should be easy to administer, and therefore one can imagine an oral agent will be much more easier to use, like oral lenalidomide, rather than something that one has to administer as an intravenous infusion or as even as a subcutaneous injection for that matter. It should be reasonable because you're going to have to dose it for a long period of time. And that's where probably generics as well have a role. So for the longest time in AML, there was this question, is there a role for maintenance therapy? And the early data, mostly phase 2 and early small center studies, was very confusing with really no significant difference in overall survival. The first study that really showed an impact on overall survival was the QUASA trial using oral azacitidine. But if you look at the design of the study, it was initially designed to enroll 460 patients, but finally went on to enroll 472 patients. Oral AZA was given at 300 milligrams per day for 14 days in a 28-day cycle after patients had completed intensive chemotherapy. But that definition of that intensive chemotherapy it's a multi-center study, was to some extent defined by the physician. And it could be at the end of 2 cycles or at the end of 3 cycles, depending on how the patients tolerated the chemotherapy. It's important to remember that this study was done in older patients, more than 55, who were considered ineligible or not in a fit state to undergo a hematopoietic stem cell transplantation. And in this setting, comparing oral azacitidine versus placebo, there was a significant improvement in overall survival, albeit small, but statistically very significant. This was the early data with a relatively short median follow-up. However, and when you look at the subset analysis, it's important to recognize that it benefited older patients as much as it benefited slightly younger patients, more than 55, more than 65. Also, it benefited patients who could not actually get the entire 3 cycles of consolidation chemotherapy, intensive chemotherapy. So there is a role for patients who achieve CR, CRI, but probably cannot go along with multiple lines of chemotherapy, may probably benefit those patients in comparison to patients who complete all the therapy. The long-term follow-up data with this trial was presented just recently in ASH. And even with the median follow-up of 54.7 months, the survival is actually still retained, saying that this is probably a true phenomena and not just a statistical phenomena. So at a very, very mature follow-up, the survival is still significant. But again, want to stress that this is in older patients who are unfit for a allogeneic stem cell transplantation. However, this data combined with the Soramin data showing the benefit of sorafenib even in post-allogeneic stem cell transplantation does challenge the concept that maintenance therapy is not required in AML. Clearly, there is benefit of maintenance therapy. We still need to evolve and understand how we optimize the utilization of maintenance therapy and which maintenance therapy we would use. So the midostaurin maintenance therapy data, at least in the initial ratified trial, was not powered to address maintenance. And the subsequent studies which was addressed to address maintenance did not show a significant benefit. Also, azacitidine as an injection post-transplantation did not show benefit. But role of oral azacitidine post-transplant has not been studied. And so there are many studies that can be done looking at maintenance therapy in various scenarios, intensive, non-intensive therapies, and how we can improve outcome in AML. The variables of generics has definitely been a game changer for us in India because we now have access to these molecules and we could potentially use them in the indications where they've already been approved. And we could also use them to study situations which have not been well addressed as in young, fit patients. Thank you. I'll stop here. I'd be happy to take questions. Thank you for your attention.
Thank you so much, Professor Vikram. If there are questions from the faculty present over here, please raise your hand. Meanwhile, we will take a question from the audience. Dr. Rahul Arora wants to know, should we wait for the molecular workup to come before starting the induction therapy for high-risk AML, as EZA or EZA plus when could be a game changer?
Yeah, so I don't have the perfect answer for it. That's why I showed you the German trial. In their setting, they would say waiting for 7-8 days is reasonable. We tend to use the markers that impact our management. We try to get the FLT3 ITD as quickly as possible, and we can in a single center. But I think today, most centers in most metros, you should be able to get a turnaround time within 7-8 days, because that's where, if you're going to bring in midostaurin, you're going to bring it on day 8 anyway. The TP53 will be a useful mutation to pick up early, because that's a situation where even in a young fit patient, you may choose not to give 7-3. Even if you, because there may be a better role for giving EZA and EZA-ven. The others, the IDH1, IDH2, at this point in time probably doesn't matter to us. And even in the West, it is not really part of a young fit patient standard algorithm in induction.
Vikram, EZA-ven really makes a difference in TP53?
We don't know the data, whether it makes a difference. It's better than 7-3, the EZA data. The Washington WashU data, which was published in NEGM, suggested that we don't have a phase 3 RCT to study that, suggested that the hypomethylating agents may have a better role than 7-3 induction. So I wouldn't say it's a phase 3 RCT, and the EZA-ven doesn't do as well as the non-TP53, even with the EZA-ven. But compared to 7-3, which may be a pretty futile exercise in that group of patients. It's in that context.
Sure. Ashutosh, your question. Unmute yourself.
You're muted, Ashutosh.
Yes, sir. Yes, sir. So my question is, can oral AZA be a upfront treatment? As what is your opinion? No data available, no doubt. So
I would not use it as upfront therapy in young fit patients. Unfortunately, there's a danger for these kind of things to be pushed beyond what it was studied and what it is recommended for. Right now, it's recommended as maintenance post-intensive chemotherapy, where there definitely is a role. And even that, I must stress, was done in patients over 55 years who were not eligible for a stem cell transplantation. I mean, this is a short talk. In a long talk, I would show you our own data on young fit patients who achieve MRD negative and transplant. The outcomes are pretty good. So we must be cautious, but I think in an older or even in unfit patients who cannot go with a full intensive chemotherapy, even with 1 or 2 cycles of intensive chemotherapy, you can go with oral azacitidine, and there's a large group of patients who would benefit from that, But I wouldn't extrapolate it straight away, say that to use it as upfront therapy either in young or in older patients.
Actually, that thing I wanted to know, whether those suppose young fit patient transplant eligible, we are not able to start chemotherapy initially, can we bridge that period with oral azacitidine? That was my basically my question.
Yeah, I personally would not do that if possible, but I can see to some extent where you're coming from. So sometimes you get a patient who is kind of little sick, you're not very sure whether he's going to make it through a 7-3. You want to try. We don't have the answers to that, so there's a fair amount of confusion in this field at this point in time, because who is a young fit patient? That is, if you even within a multi-consultant setup like ours, it's difficult to get consensus at times.
Thank you very much, Ashutosh, for asking that question.
Thank you, sir. Thank you.
There is a lot of pushing of the oral ASA going on in this country in last 3 months. And thanks, Vikram, for clarifying that. That's all the time, Vikram, we have for questions to you. We will move on to the panel discussion now.
Thank you, sir.
Thank you, Vikram, for being with us. And I hope you will be with us for the next half an hour.
Yes. I need to step out, sir. My sincere apologies.
Carry on. Thank you. So the next session is also supported by Dr. Reddy's, and this is a panel discussion. Same subject, the emerging role of oral azacitidine and midostaurin in AML management. Moderator for the panel discussion is Professor Maitri Bhattacharya, Director, Institute of Hematology and Transfusion Medicine, Medical College, Kolkata. The panelists, and I hope all of them are there, are Dr. Ashutosh Panigrahi, Bhubaneswar, Dr. Deepesh Lad, Chandigarh, Dr. Chirag Shah, Ahmedabad, Dr. Mahesh, Bengaluru, Dr. Padmaja Lokireddy, Hyderabad, Dr. Ganesh Jaishetwar, Hyderabad. So over to Dr. Maitri.
A very good evening to you all. Just now we learned a lot from Dr. Vikram's talk about the newer agents in AML treatment. So this will be just how to apply all this reagent in a practical case, like what are the options, how we can manage the case. Like my slides are visible?
Yes.
Yes, madam.
Okay. So sir has already introduced the moderator and the panelist also. So as you know, it's known to everybody that 3+7 is the gold standard for treatment of AML. Whatever is there, we give our patient 3+7 only. And if the patient is eligible and indicated, then go for transplant. Otherwise, there is nothing after consolidation therapy. So, but it has been seen that from 1970 to 2017, that this 3+7 effect is translated to the patients who are less than 60 years. You can see the gap. And 2070, so the result is much better. But if you consider patients more than 60 years, it's a narrow zone only. So the response was not good at all in elderly patients with this. And this was a decade for molecular decade, we can say, in all the hematological malignancies, and that is applicable to AML also. So a lot of molecular markers were discovered for AML, and the people are trying to modulate the therapy as per the molecular markers. Also, to some extent, we can say this is individualized therapy. So let's come to the practical patient, a 62-year-old man. There's no comorbidity, absolutely fit and fine, presented with weakness and fever. And after that, there was 60% blast in the bone marrow. There was strong CD33 expression, and cytogenetic analysis was normal. So my question to Dr. Ashutosh is there, like at this, you have this data only. So what are the other things you want to investigate for this patient? Primarily looking at, aiming at the choosing the protocol or therapy. Dr. Ashutosh, you are muted.
Yes, madam. So now the therapy is based on the stratification. Most of the concern is focused on the molecular abnormalities associated with AML. So we can categorize the molecular abnormality into two main categories. One is mutations and rearrangements. So, but practically what we do, we mostly send to labs, commercial labs, where they make a panel. But if you choose what tests need to be done, we can categorize into three ways. Those who have importance in classification of disease, like MPN1 mutation, CBPA mutation, RONX1 mutation. This can classify the different categories of AML. Next, where targeted therapy is available, like FLT3 mutation or IDH mutation, and where we can prognosticate, as Dr. Bikram told, that if T53 is there, probably 3+7 will not work, or it will be more difficult to treat. So these are the mutations in addition to cytogenetics, because cytogenetics is also important in this situation. So these are, for practical purpose, these mutations are only required. There are so many other mutations that depends on in which scenario we are dealing with, like in a children or in a younger patient where germline mutation is suspected. There we can go ahead with different kind of molecular analysis. So these are the tests that is required. In addition, other tumor lysis syndrome, then fitness assessment has to be assessed before starting treatment.
So the list is a long one, but I think a few suggested, and as Dr. Ashutosh told clearly, we should include those markers for which a targeted therapy is available. As IDH1, we should include into this panel. This was a panel which was suggested in 2017 by ELN for at least minimum panel for investigating the molecular markers in a patient of AML. So this patient was found to be FLT3 ITD positive, IDH2 positive, and there was a T53 mutation also. So Dr. Deepesh, how we are going to prognosticate this patient?
Right. So we still use the ELN.
Cytogenetics is normal.
Right. We still use the ELN classification to re-stratify these patients. So as per the ELN 2017 guidelines, this patient with TP53 mutation would straight away fall into the adverse risk. In fact, the ELN says that TP53 mutated patients are, in fact, very adverse risk patients, more behaving worse than adverse risk patients. So definitely, this is an adverse risk patient. Straightforward, depending on the TP53 mutation.
So like this patient, if we consider the molecular marker, this is also ELN 2017 classification for classifying patient as favorable, intermediate, and adverse risk group. And the patient is FLT3 positive, wild type NPM, and these are the other markers. Then they said this is to be considered as an adverse prognostic marker. So this patient goes to a high risk group in spite of a normal cytogenetics. So, Dr. Chirag Shah, like, what do you think? Like Dr. Vikram told us, a basket of drugs which has come for AML patient. So, for this patient who is IDH2 positive and FLT3 positive also, what should be the best therapeutic option in 2022?
So, for
Dr.
the
Chirag Shah.
induction, yes. So, for induction in this patient,
this is fit and fine patient, though age is more than 16.
Right. Yes, but with TP53, I would prefer the azacitidine venetoclax option, since the chance of 7+3 working is low.
Do you think a patient with a FLT3 mutation and T53 mutation, azacitidine is a good choice?
So FLT3 mutation in the, I mean, if you see the NCCN guideline for elderly, even with FLT3 mutation, upfront azacitidine venetoclax is considered a first line option.
So you want to go for a combination or aza only?
So azacitidine and venetoclax combination. Yes.
So you want to go for a frontline azacitidine and venetoclax combination. Okay.
Right.
So the treating physician gave this patient 3+7 plus midostaurin as the patient was fit and fine, and there's no comorbidities also. So with this 3+7, this patient received it in induction therapy. So the question goes to Dr. Mahesh, like this midostaurin or FLT3 inhibitors, like is there any role in consolidation, maintenance, or what exactly is the role of this FLT3 inhibitor in the treatment of AML? Dr. Mahesh, please. Is Dr. Mahesh there?
Definitely, there is a role for midostaurin in consolidation as well. because more patients will go into a better disease-free survivals and will be able to take them up for upfront transplant. We can divide FLT3 ITD patients into those with a low allelic ratio and a high allelic ratios. And since this patient already has a high allelic ratio, and that with TP53 mutation, the chances of him relapsing are quite high. So there is significant role of midostaurin in consolidation as well. So I would like to take him up for consolidation along with midostaurin, and then take him up for transplant if we find a suitable donor.
Yeah, Dr. Padmaja, do you agree with him that midostaurin should be given in consolidation also?
Madam, you need to unmute yourself, Dr. Padmaja.
Dr. Hello? Dr. Padmaja? Then we will go to Dr. Ganesh. Dr. Ganesh, do you agree with him that it should be given in consolidation also?
Can you hear me?
Yeah, yeah. Okay, Dr. Padmaja.
Sorry. Yeah, it all depends on whether we're thinking about this patient is fit enough to go for transplant, and the end of induction, has he attained a molecular remission, and how fit he has sailed through the 3+7 before we plan for either. I wouldn't go for a midostaurin maintenance upfront. So I would want to take him through transplant once he attains a deeper remission, ideally molecular remission, and use midostaurin as a post-transplant maintenance to prevent a relapse, as these patients, he's obviously very high risk. Over 60 is the biggest risk factor, and FLT3. So this patient has got a 30% chance of relapse of his leukemia, despite he gets a CR1 with a molecular remission upfront. So at the end of the first 3+7, I would give him one consolidation, provided he has attained a complete remission molecular wise, and then go for a transplant with a post-transplant maintenance with midostaurin, with a view that he has got a high risk of a relapse with a maintenance. That would be my strategy.
So these are the studies what Dr. Vikram already discussed regarding the midostaurin. These are the, but it was found that when they have analyzed the subgroup, there was the benefit was not that high as a total group, and much more of the benefit was because of transplant, not because of the drug, because they were eligible for transplant. They went into remission. So, like now FDA has approved it for induction therapy only. You cannot give it like as per FDA. Of course, you should not give it. And there is no role of maintenance therapy other than transplant with midostaurin. So this patient blast also expressed CD33 very strongly. Dr. Ganesh, do you think that GEO will be an alternative choice for this patient?
Madam, this patient is a ultra high risk AML elderly person who has TP53 mutated. He is IDH2. Of course, IDH2 is not a high risk marker. It's a, but then FLT3 ITD high allelic ratio. So definitely CD33. If he is going for transplant, if transplant is an option, I will not opt for CD33 antibody, because VOD incidence is going to be extremely high. CD33, the gemtuzumab is most, the data shows its utility most in the core binding factor favorable risk AML who are going to be just on chemotherapy. So for me, I don't think there is any role of gemtuzumab ozogamicin if the patient is going for transplant. Ultimately, TP53 mutated AML, even with transplant, the outcome won't be far good compared to other high-risk AML subgroups. But that is the only consolidation platform which is going to offer him whatever best possible long-term leukemia-free survival.
Okay, so when I look at the data, because all of us know that ozogama, there is a re-emergence in between. It was not indicated, it was removed. After that, it has come back into the field of AML. So when the data was again analyzed, it has been found that you can see here, this is a favorable risk group and the gap is a wider one. So it's more effective in the favorable risk group than in the high risk group patient, as already Dr. Ganesh has mentioned. And there was a meta-analysis which actually comprised of 5 RCTs, and it showed that this is more effective in younger patients with favorable cytogenetics and FLT3 So even if it's available, this is not applicable for our patient, for this patient only. So the patient achieved a CR after induction. He completed 2 high dose RRC and he doesn't have any sibling. So what next, Dr. Ashutosh?
Madam, means elderly patient, high risk, no, not a candidate for transplant. I will choose a oral azacitidine maintenance because midostaurin maintenance is not yet recommended at this point of time. So that's why only that is recommended drug is oral azacitidine. So I'll go ahead with oral azacitidine and observe for relapse. Of course, we'll observe for feasibility of transplant also in the meantime.
Okay, so all the other panelists agree that this patient, when the patient has achieved remission, the patient should be, we should put the patient on oral azacitidine maintenance.
Yes, oral azacitidine definitely is a reasonable option, and in the pivotal trial where it is studied, this is a very, I think, matching population. I would like to ask again about the transplant. I would be very, very cautious referring this patient for transplant with TP53. Any chance of transplant benefiting long term is for 10%. It's, I think, very, very low benefit.
So this
rate.
patient was put on oral azacitidine maintenance only, and the data already discussed by Dr. Vikram. This patient was tolerating the therapy well. After about 18 months, he developed severe cytopenia and bone marrow aspiration showed again a relapse. This time FLT3 was again positive and IDH1 was positive. So what kind of therapy would you like to choose if you want to start another FLT3 inhibitor or anything else for this patient? Dr. Dipesh.
Yeah, so this patient has kind of relapsed within a year of achieving remission. So
this time, surprisingly, we didn't get T53, only FLT3 IDH was positive.
This is after 18 months. And there is no TP53. That is surprising because I wouldn't expect the TP53 to go away without a transplant. I know the patient has already progressed and his age would have also advanced. And his performance status at this point of time would be important in terms of deciding whether it will fit for another salvage chemotherapy, transplant, haplotransplant. So those are the considerations. So another FLT3 inhibitor, other than that, at this point of time, definitely thinking in terms of novel drugs like venetoclax plus azacitidine to get him into remission if he is not fit for salvage chemotherapy. I'm not sure about whether other FLT3 inhibitors are going to make a lot of difference at this point of time.
Okay, so there is a role of other FLT3 inhibitor also, like even in cases of patient who has already received midostaurin, so they were included in the study and gilteritinib was studied. The result was not much promising, but there was some effect. You can see the first year overall survival was 37.1 and the second year was 20.6. Compared to salvage chemotherapy, this was 16.7 and 14.2. So this option is there, though it doesn't look like very promising. So this patient also is IDH1 inhibitor. And from the very beginning, we are not considering we are not targeting IDH, whether it's 1 or 2. So Dr. Chirag, what do you think? Like, was there any role in this patient of IDH inhibitor?
So there are ongoing studies of combining FLT3 inhibitors with IDH1 inhibitors in a patient like this, having multiple targets, and that can be considered. Since I don't have any personal experience and I'm not sure about the availability of IDH1 inhibitors in India, but there are definitely studies ongoing for the combination.
Okay, like what my question is that in presence of FLT3 inhibitor, FLT3 mutation, like is there any choice for going for IDH inhibitors?
Yes, adding that is a possibility. So not alone, IDH1 inhibitor plus FLT3 inhibitor.
So you want to combine IDH1 inhibitor with FLT3 inhibitors, yeah?
Yes.
Okay, I have not come across those type of studies, but a lot of studies are going on with IDH1 inhibitor. These are the studies with IDH1 inhibitor, and these are the responses. They have shown that mostly in combination, studies are mostly in combination with azacitidine, and there was a good response also. Only thing about the IDH inhibitors, we need to keep in our mind that sometimes it gives rise to a differentiation syndrome like thing, though the like incidence is not very high, it's around 4% only, but we should also keep this in our mind. And these are the other combination which are going on with IDH1 inhibitor. These are studies going on till now. Of course, in future, we'll have the reports how these studies will help the patients of AML. So this patient has FLT3 IDH1. We thought of targeting these things, but can we have any other options like salvage option for this patient? Like at the beginning, I think who was saying about venetoclax? Somebody was saying about venetoclax from the very beginning. I think it's Dr. Dipesh or Dr. Chirag, somebody. So what do you think is the role of venetoclax, and why do you want to choose venetoclax for this patient? Dr. Mahesh, why he said that venetoclax is one option, frontline option?
So the combination of demethylating agent and venetoclax, we have at least around 20 patients, and at least 50 to 60% of them had a good disease-free survivals, touching up to 12 to 14 months of therapy, and they had a good quality of life. Of course, in the initial periods, you got to watch for a lot of toxic effects like febrile neutropenia, which is usually seen in around 50 to 60% of the patients. Even in this kind of high-risk group, especially one with FLT3 ITD positive, as well as having a P53 mutation, especially demethylating agent like distabine, if it is just a somatic P53 mutations, they really work well when compared to other salvage chemotherapies. And we have two patients who had P53 mutations who went into durable remissions. And one of our patients is a retroviral disease patient, P53 mutation, germline, not germline, somatic mutation positive. And she is almost taking like distabine, only distabine for almost like more than 1.5 years now. She still continues to be in a good remission. I think a combination of demethylating agent, venetoclax, is still a good salvage regimen for this patient who has relapsed on FLT3 inhibitors, especially considering his age.
Dr. Padmaja, like studies regarding frontline venetoclax in AML patient?
Yeah. So just going back on to this patient, the fact that we decided that he is not fit or whatever, he has got no sibling, but we've not looked at alternative donors. That means we've decided that he is not a transplant eligible, or is that if he has not got a donor, is that not a haplo option? That would be my first thing I would look at. If he was becoming too ill that he is not transplant eligible, probably I would have a very frank discussion with the patient. Whatever we do, it's going to be a prolonging the time, and he is going to have relapses. Even further treatments with the newer targets is only going to give him some median survival, but not a cure. I think that becomes a very clear-cut thing. If there is no transplant, this patient could never be cured. So adding on to the second line, giltartinib, the FLT3, if this patient was in UK at that time, he was not eligible. He would have gone on a maintenance. If he relapsed, he would go on a clinical trial. With the other FLT3, a single agent giltartinib has got a good response rates. Once they attain a remission, again, you're looking at the opportunity of taking them through a transplant. If there is no transplant option was discussed because he was not fit enough, even for a haplo or anything, he becomes a palliative, because all these options, adding in AZA venetoclax with the cost, we are looking at a median survival, overall survival is about 24 months. So it's not a long-term cure. Either hypomethylating agents with AZA combination, yes, there is a 50 to 60%, even in a T53 or FLT3, but it's not a long-term cure. So we're looking at the opportunity where we can take this patient through transplant, is at least the haplo, and looking at the post-transplant maintenance strategies. It could be FLT3 giltartinib, which could be a maintenance in the clinical trial. So that's how I would look at the.
So venetoclax initially came as a cases of relapse refractory, but now it's indicated in de novo patient also. So like for these patients, like practically if we think those 62 years absolutely fit and fine, no comorbidity, should we go for venetoclax combination at the beginning as suggested by some of you, like Dr. Ganesh?
Madam, yes, thanks to COVID, I had about more than 20 patients who were because
chronological age is not that important for malignancies. Like this patient is absolutely fit and fine.
Yes, madam. So even if it is chronological age, or even for younger, fitter patients, if by some reason you are not able to take them for upfront cytoreductive intensive chemo-based induction, there these combination of aza-venetoclax has proven very, very useful. I had at least 7 or 8 of such patients, even in the patients below the age of 50. Either they were COVID positive, they have some very bothersome pneumonia at diagnosis on assisted ventilation. So these patients have really done well, as Dr. Mahesh has pointed out. So rather than AZA alone, and AZA plus venetoclax definitely has a better response rate. And as you, madam, correctly pointed out, a lot of trials are coming up for unfit chemo ineligible patients. This combination is really proving quite vital and useful. But another important fact, this patient has been IDH positive. IDH inhibitors, though useful tool for treating these patients for whatever, either palliative or curative, had it been used in the upfront setting, the cost is quite high. Per month, cost is somewhere between 6 to 9 lakhs. And this is for a patient who is not going on for transplant, this is until disease progression. So it is practically impossible. The other important molecule like azacitidine has been proven in a subset analysis that IDH mutated, IDH1 and 2 mutated NPM1 mutated patients, the aza-venetoclax combination works well. So I would have used it upfront, and being a transplanter, and if the patient is fit and healthy, so I could have taken him for transplant. But even now at this second setting, at relapse setting, of course the chances of him going into remission will be very less. But I will, at this point of time, at least I will use aza-venetoclax plus FLT3 inhibitors.
Yeah, while I was searching the literature, I'll show you one interesting thing. Like this study has shown that AZA plus VEN is effective in IDH1, FLT3, P53, all the mutation. So, and the results are significantly good results. So, like for these patients, what I agree with, as suggested by some of you, AZA and plus venetoclax should have been the first front line of therapy, considering the underlying mutations of these patients, where this combination will act against all these mutations. So we expect something other than going for 3+7 plus midostaurin. This would have been a better choice for these patients. So these are the other studies with what venetoclax is going on. So do you think, like some of you are in favor of transplant? So do you think this patient should have done a mud transplant in CR1? Dr. Chirag.
Okay, so as I said earlier, I would discuss this with patient, but unlike other patients, I would be very reluctant to subject him to transplant, for the reason that in TP53, the long-term survival even with transplant is very low. And somebody who does not have a matched sibling, at 60 years of age, there is at least a 20 to 30% upfront mortality of transplant, and probably more so in India. So this is even the international, I think at 60 plus, the mortality is very high and the morbidity. So all that the patient has to understand, that for the 10% potential for long-term survival, how much is he willing to take?
Yeah, I agree with you that though the data has shown that for high-risk patient, even if it's not a sibling there, a MART is a good option compared to chemotherapy. But for a patient more than 60 years, definitely the problems are there, and also T53 mutation. So these are the data which was in patients high-risk group, but not a not patients group in elderly patients group, or mutation study has not been shown. So though looks like lucrative that the result will be better than consolidation chemotherapy, practically it's not a good option for this patient only to undergo a MAT transplant at CR1. So if I sum up a diagnosis for any AML patient, we should assess the molecular marker in addition to cytogenetics also, and can be divided into three groups: fit, unfit, and frail. This is from ASH 2021. And as per mutation, we can choose the therapy: FLT3 mutation 3+7 plus midostaurin, CD33 plus GEO. But I told you the group where GEO will be effective. It will not be effective in all the groups. Even CD33 expression is there. Once the patient has achieved the remission and the patient is a fit and otherwise indicated for transplant, transplant is the best option. And if it's not, then maintenance therapy oral with oral AJA is the best option for fit patient also. And these are the option for unfit and frail patient at de novo for de novo AML. And at relapse and refractory, again the patient should be reassessed for the molecular markers and cytogenetic studies, because I showed you that some of the markers changed in our patients. So, and you'll have to target the molecular marker. And FLT3 mutation, it's indicated even if the patient has received midostaurin. There's other FLT3 inhibitors you can go for. And if the patient achieves this here, the only option for the patient is to undergo a stem cell transplant. And these are the other option where you can go for a salvage chemotherapy also to bring the patient to our and stem cell transplant. So what is the thing is that for relapsed patient, ultimately, if you want, whatever chemotherapy you give, whatever target mutation you target, ultimately your goal should be for a transplant, unless and until the patient is eligible for a transplant and will be able to do a transplant, the long-term effect will not be a good one. So this is what we can say regarding the management of AML patient at diagnosis and also at the time of relapse and refractory, depending on the mutations and the newer therapies what are available to us. So I thank all the panelists to be with me and to help me also with their suggestion to come to a conclusion for treating patients with this type of complicated mutational reports. Thank you all.
Thank you, madam. Thank you.
Thank you, Dr. Maitri and the panelists. There are some questions from the audience if you would like to take them. One is there a role of decitabine in maintenance?
Yeah, any of the panelists who would you like to take? Dr. Ganesh?
Madam, maintenance therapy is something which is to maintain remission, and it should not be very much toxic. So we are more tuned to azacitidine nowadays with the availability of oral azacitidine. We are tuned to using more of azacitidine, but yes, there is a literature of maintenance decitabine, but the standard recommendations for decitabine dosages as is used in the unfit patient, elderly patients, that dosages probably won't be feasible to be used on a long run as a maintenance. But yes, there is enough literature of decitabine being used as a maintenance across.
But Dr. Ashutosh, like azacitidine data, it's not a time-tested thing. Azacitidine data with us is not a long-term data. And I've given a few patient toxicities, like 2 of my patients I had to discontinue because of persistent diarrhea. So toxicities are also there. So comparatively, decitabine is definitely a very benign drug. Most of the patient tolerance without any toxicity. So depending on the patient, we have the option, though the results are maybe, we don't know. There is no comparative analysis of both these drugs.
Madam, I can add to something for this question. I had one patient who was intolerant to azacitidine. So that patient was a 72-year male with a coronary artery disease. He had, basically he was not tolerating because of recurrent cytopenia and all these things. So when I discussed that, are you interested to go ahead with decitabine. Surprisingly, he told yes, and I continued with decitabine. For last 6 months, he is on decitabine, and he is tolerating also. So I don't know, a few patients are there with this like maintenance decitabine, they are tolerating. I can go ahead.
I don't know where Ashutosh was there. Like I'm working in a government hospital where most of the patients cannot go for a transplant for financial and other reasons. So we put them who on decitabine maintenance after consolidation, and many of the patients are surviving 3 years, 2.5 years, 4 years, and I think that's good enough for a patient for whom we cannot go for transplant. We I think this is a good option for a country like India again.
So if I may add, hope we are using the word maintenance in a patient who has had an intensive treatment and following the intensive we're maintaining, rather than a non-intensive patient who is continuing on until the disease progression. So I think whoever has asked the question, I'm just saying non-intensive, we don't use the word maintenance, we just keep going and patients do tolerate until they relapse. So yeah, if they've stopped in between the intensive, if they've had a 1 cycle and they couldn't tolerate, we switch to non-intensive chemotherapies and we keep going as per the non-intensive schedule until the disease relapse. So whether we use that maintenance at that time or not, but we still use the maintenance azacitidine or decitabine, how you would do in a non-intensive setting until the disease progresses.
Thank you. There is one more question: role of mTOR inhibitors in the management of AML.
Anyone, Dr. Dipesh?
I think it's kind of experimental, as I understand. Not yet approved.
Another question is role of aurora kinase inhibitors in treatment of AML.
Same experimental, not yet approved.
Okay, last question is, can we combine FLT3 inhibitors with venetoclax as maintenance therapy for AML patients who are FLT3 positive AML, who are in remission, and who are not a candidate for transplant?
So this is whether we'll combine inhibitors with venetoclax for maintenance. Anybody wants to take this question? Anyone?
This should still be considered as experimental. So studies ongoing, but not standard yet.
There are studies for maintenance midostaurin, but not for a maintenance venetoclax. There's definitely a survival data when you use 12 cycles of maintenance in a patients who have had upfront and in the second cycle consolidation and followed with a maintenance midostaurin for 12 cycles, and not for the venetoclax. Thank you.
Venetoclax is undergoing studies with other inhibitors, definitely, but as a maintenance therapy, venetoclax inhibitor, I think studies, we need to wait for the studies to come up for this type of combination. Yeah.
Yes, and venetoclax is not an easy drug. I think people should realize that even though it is a tablet, it is one of the most difficult drugs, and at least initially you can get very severe cytopenias. Plus, maintaining that also, you can have very severe bone marrow depression. So it is not an easy drug.
I think logistic problems are also there. It's difficult to get it through in an open market. So that problem also is there whenever we are using venetoclax. Maybe in future it will not be there. Yeah.
Thank you, Dr. Maitri. That brings us to the end of this panel discussion. Thank you very much to all of you, and thanks to Dr. Reddy's for supporting this activity. Our today's satellite symposium comes to an end. See you all if you are joining us tomorrow at 6:30. Thank you. Bye-bye. Good night.
Good night.
Thank you and good night.
Thank you. Good night.